I'm sure everyone here has learned or read about this topic before. So today we just going to revise a bit and we relate it more with our main subject for today, which is tracheostomy. The respiratory system is the set of organs that allows a person to breathe and exchange oxygen and carbon dioxide throughout the body. It can be divided into upper respiratory tract and also lower respiratory tract. Upper tract consists of nasal cavity, pharynx and larynx, while lower tract consists of trachea, primary bronchi and also lung. It also can be divided into conducting portion and also respiratory portion based on its function. Conducting portion is portions that transport air, while respiratory portion is the portions that carry out gas exchange. This diagram showing both conducting and respiratory portion. So I will show you the conducting portion first. It starts with from the nose. The air will enter the nasal cavity, and then we'll go through the pharynx and through to the larynx, enter the trachea, and goes into the primary bronchus and until the terminal bronchioles. And for respiratory portion, it consists of respiratory bronchioles, alveolar duct, and also alveolus. Upper respiratory tract composed of the nose and its cavity, paranasal sinus, pharynx, and larynx. It contains only the conducting portion of the respiratory system, and it made of a layer of pseudostratified ciliated columnar epithelial cells that secrete mucus. And this mucus helps to grab any particles or contaminants, and then cilia will then move this mucus towards the mouth. Okay, so we start with the nose. It can be divided into two halves by the nasal septum. So you have sinus as their neighbor. So we also have external opening, internal opening, and also you can see there's a few, three concha here, which is inferior concha, middle nasal concha, and also superior nasal concha, or the other names you call it turbinate. This function of the turbinate is to increase the air turbulence, so most of the air will get contact with the mucous membrane. Now we move on to the paranasal sinus. We have four pairs of paranasal sinus. Here, frontal, ethmoid, and then sphenoid at the back, and also maxillary at the cheek area. And then the function of paranasal sinus is to decrease the scalp bone weight, to warm, moisten, and filter the incoming air, and also to add resonance to the voice. For pharynx, it is a common space used by both respiratory and also digestive system. It commonly called throat, originates posterior to the nasal and also oral cavities and extend inferiorly near the level of the bifurcation of the larynx and also esophagus. A common pathway for both air and foods. Laluan yang sama untuk udara dan makanan, dan dia boleh dibahagi kepada tiga bahagian. Pharynx ada tiga, iaitu nasopharynx, oropharynx and also hypopharynx. So nasopharynx ni yang air masuk, oropharynx makanan masuk, and then hypopharynx dibahagi kepada dua, which is larynx dekat depan dan esophagus dekat belakang. And then for larynx, also known as voice box, peti suara, it is a short, somewhat cylindrical airway ends in the trachea. Dia bersambung dengan trachea dekat bawah dia. So it prevents swallowed material from entering the lower respiratory tract. So the main function of larynx is for protection of the lower airway. And also it helps to conduct the airway from the upper respiratory tract to the lower respiratory tract, and also helps to produce voice or sound. Okay, this diagram shows you larynx from the front view, dari depan. Okay, so it is made of several cartilages. We have thyroid cartilage, cricoid cartilage, and also epiglottis. These are all unpaired cartilage of the larynx. It also made up of membranes and also ligament lah. So the other important things that I would like to show is the incision site that we make on our patient who requires tracheostomy. So kita akan potong dekat bahagian depan anterior aspect of the trachea at the second and third tracheal ring. So we call this one mid incision. We also have high incision and lower incision, but we prefer this type of incision at the second and the third tracheal ring, because if higher up, we only reserve for patient with larynx CA, where we will plan to do laryngectomy later. Apart from that, if you do higher up, there's a risk of perichondritis over the cricoid cartilage and also risk for subglottic stenosis in future. While if we do lower incision, the risk is it is near to the big vessels around here, and also it will disturb the placement of our tracheal tube, since the tube will impinge on the sternum. Okay. So this is the axial view of the larynx. The musculum wall aid in voice production and the swallowing reflex. Here is glottis, the superior opening of the larynx, and epiglottis um, um, here. This is the epiglottis. It is to prevent the food and drink from entering the airway when swallowing. So we move on to lower respiratory tract. It contains both conducting and also respiratory portion. So conducting airways consists of trachea, bronchi up to terminal bronchioles, while respiratory portion consists of respiratory bronchioles, alveolar duct, and also alveoli, as I mentioned in my previous slide. Okay, so this diagram again shows the same thing, conducting zone of the lower respiratory tract. Trachea is a flexible tube, also called windpipe. It extends through the mediastinum and lies anterior to the esophagus. Duduk dekat depan esophagus and inferior to the larynx. So boleh bayang dia bawah kepada larynx tadi. Peti suara, bawah peti suara is our trachea, and dia lies anterior, di depan esophagus. So the anterior and the lateral wall of the trachea are supported by C-shaped tracheal cartilage. Cartilage rings reinforce and provide rigidity to the tracheal wall to ensure the trachea remains open at all times. So trachea tu tak collapse. Okay, then the posterior part of the tube lined by the trachealis muscle, and it also lined by the ciliated pseudostratified columnar epithelium, similar as upper respiratory tract. Okay, at the level of the sternal angle, the trachea bifurcates into two smaller tubes called right and left primary bronchi. Each primary bronchus project laterally toward each lung. So daripada trachea, then bahagi jadi right bronchi, left bronchi. And then the most inferior cartilage, tracheal cartilage, separates the primary bronchi at their origin and form an internal ridge called carina. So carina tu is a junction lah of two main bronchus. So we have right, left, and this is the carina. So bronchial tree originate from the left and right primary bronchi, progressively branch into narrower tube as they diverge throughout the lung before terminating in terminal bronchioles. Right, primary bronchus is shorter, wider, and more vertically oriented than the left bronchus. Hence, foreign body likely to lodge in the right primary bronchus. So this diagram shows the respiratory zone of the lower respiratory tract. Each lung has a conical shape. Dia bentuk macam cone. So its wide concave base rests upon the muscular diaphragm. So, and its superior region, paling atas, we call it apex lah. So it projects superiorly to a point that is slightly superior and posterior to the clavicle. Both lungs are bordered by the thoracic wall anteriorly, laterally, and posteriorly, and supported by the rib cage. Towards the midline, the lungs are separated from each other by the mediastinum. So left lung divided by two lobes by oblique fissure. It has cardiac notch lah, accommodates the heart. And then right lung divided into three lobes by the oblique and horizontal fissure located more superiorly in the body due to the liver on the right side. So these are the next slide will be clinical application that related to the anatomy of the respiratory system. The indication for tracheostomy is mainly to bypass the obstruction in the upper airway. Selain daripada because of prolonged ventilation or part of surgery ataupun neurological problem, the main memang untuk for airway obstruction, upper airway obstruction. So upper airway obstruction, the causes can be further divided into subgroup, which is congenital, for instance, like subglottic or upper tracheal stenosis, laryngeal web, laryngeal hemangioma. Infective in pediatric age group mainly are the most common is acute epiglottitis, laryngotracheobronchitis, or in adult like Ludwig angina or retropharyngeal abscess. And then in malignancy, for instance, advanced tumor of larynx, base of tongue tumor, or hypopharyngeal tumor, and then trauma or inhalational injury that causing edema of the upper airway, and then vocal cord paralysis or foreign body. Okay, so gambar ni menunjukkan upper and lower airway. So tadi saya dah listkan indication untuk buat tracheostomy. So slide ni just nak tunjuk a few or to give some idea kenapa upper airway obstruction adalah indication untuk kita buat tracheostomy. So dan selalunya obstruction tu bermula dekat kawasan oropharynx. Kenapa bukan ke atas ni? Sebab kalau apa-apa obstruction dekat atas ni, pesakit masih boleh nafas dengan mulut. Jadi kalau obstruction dekat atas, patient bernafas ikut mulut, jadi selalunya tak ada masalah lah. Tapi kalau obstruction dekat bahagian ni, so dia dah menyebabkan the lower airway tak dapat, oksigen tak boleh nak masuk ke lower airway. Okay. So for instance, this patient, he has Ludwig angina. Ludwig angina ni adalah collection of pus dekat dalam sublingual and also submandibular space, menyebabkan edema of the surrounding and also of the tongue lah, pushing the tongue backwards. So bayangkan lidah ni ke belakang, tertolak ke belakang. Jadi dia akan obstruct the upper airway. So menyebabkan patient boleh dapat stridor dan juga collapse lah subsequently. Okay, so yang ni adalah growth dekat base of tongue. So macam base of tongue carcinoma. So dia tumbuh ke belakang menyebabkan patient dapat masalah dengan airway. And also kalau ada apa-apa cancer, tumor dekat pharyngeal wall pun boleh menyebabkan patient dapat upper airway obstruction. Okay, so begitu juga dengan kalau masalah ni lah dekat bahagian larynx, macam vocal cord paralysis, bilateral vocal cord paralysis lah, ataupun foreign body, macam kita pernah dapat satu patient dia makan fishball tu sangkut dekat kawasan sini. So bila dia sangkut dekat kawasan sini, so dia tutup larynx menyebabkan udara tak boleh masuk lah. Ini adalah gambaran dari tepi. Kalau kita dah insert the tracheostomy tube lah. So any obstruction up here will be bypassed. So that is the function of tracheostomy, to bypass any upper airway obstruction. The second point that I want to emphasize in relation to the anatomy of our respiratory system is during suction. Okay, suction is one of the important steps lah in trachea care for most of our patients. Okay, so however, it has to be done gently because to avoid traumatic suction lah. Okay, so imagine this green color here is our suction tube. Imagine if you insert it beyond our trachea tube. Okay, masukkan melebihi trachea tube ni. So bayangkan dia ni dah ke bawah. So apa yang dia akan suck? Dia akan suck this mucous membrane on the trachea. So kalau dia stuck mucous membrane ni, dia akan menyebabkan laceration lepas tu bleeding, and subsequently akan menyebabkan granulation tissue yang will then akan obstruct kita punya tracheostomy tube. So back to the main function of why we want to perform suction is actually to maintain the patency of the tube. So sepatutnya kita suction dekat dalam tubing sahaja, not more than not beyond the tube. Okay. And then the cuff balloon and the pressure necrosis. Okay, as you all know, kalau ventilator patient lah, selalunya they require this tracheostomy tube to be inflated. However, it has to be intermittently deflated. Why? Because there are the risk untuk develop pressure necrosis, and some more not to overinflate. Maksudnya tak nak terlalu balloon tu terlalu overinflate, sebab itulah nanti ada risk pressure necrosis dekat tracheostomy wall. So macam mana nak tahu? Selalunya kalau dekat ICU kita akan ada manometer. So selalunya kita akan set around 20mm mercury. Kalau tak pun, kalau ada dekat ward, so staff nurse kena deflate and inflate intermittently lah, supaya kita dapat elak berlakunya pressure necrosis. Okay, the third point is the cuff balloon and dysphagia. So kalau ingat balik tadi saya punya slide yang awal-awal, saya ada mention yang belakang trachea kita ada esophagus. So bayangkan kalau kita overinflate the balloon, so nanti dia akan bagi tekanan pada esophagus. So jadi sempit lah esophagus tu. So bila patient yang boleh allow orally post tracheostomy, tiba-tiba dia kata susah nak telan, so kita kena check balik sama ada kita overinflate ke kita punya tracheostomy balloon tu. Okay, so thank you for listening to me. The next topic is about physiological changes in post tracheostomy patient. So make sure you guys stay awake, can get some snacks in between the lecture. Nak makan nasi lemak pun boleh, nak makan soto pun boleh, apa-apa je lah supaya tak mengantuk, because I guarantee this whole course is going to be fun and beneficial. So hope everyone won't fall asleep and don't miss any of the lecture. So that's all. Thank you.